Data has become the magic ingredient, the factor X in personal and public healthcare. The collection, understanding and interpretation of data is informing the medical landscape, decision-making by practitioners and outcomes for patients. This session will highlight the path from research to real-life application. It looks at what industry and academia can do to coordinate more and fill in the gaps, and it considers what healthcare can learn from other sectors. We're going to start this discussion with Dr. Caroline Uhler, who's the Associate Professor at the Massachusetts Institute of Technology in the United States. Caroline's going to give us an overview of her research and how it is informed by data science. Caroline, welcome. Over to you.
Thank you so much. So exciting to be here. So let me start by giving a bit of context and maybe explain what unique opportunities I see at this intersection of data science and biomedical sciences, and then also how my research fits into this. So the biomedical sciences have really seen a data explosion in recent years, as was just said. In fact, a single lab can produce as much data as the full movie corpus of Netflix. And just to give an example of, what is the data that is becoming available or has become available, humans, we have like about 20,000 genes. And so nowadays you can routinely measure the expression of all of our 20,000 genes in single cells. And then you can even do this for every cell in a tissue section. And then, on a particular person, you can then combine this information with, the genetic information of the whole DNA. And in addition, you can get all kinds of different imaging modalities like MRIs, angiograms, etc. And so, and what is really exciting is, of course, the 21st century has not only seen this great revolution in biological technologies, but also in the data technologies. I mean, I think we all know that machine learning is everywhere now in all different kinds of technologies. And so to me, I think there is a huge opportunity in really this convergence of these two technologies. What we can do with all of this data and with this particular convergence is in fact go like this extra step of like not only understanding the units of life. So what I mean by that, right, we have had like through the data sets, we know now what is the genetic information on the DNA, what are, the different kinds of cell types that we have in our body. So these would all be the units of life, but I think we can even go a step further and look at the interactions between the units. So really understand or try to start understanding the programs of life. And so that would, for example, be how do genes interact in order to build the different cell types? Then how do the different cell types interact in order to get together and form tissues? And then link that back all the way to the DNA and try to infer how does all the genetic information actually give rise to the particular phenotypes at the organism level. And so that's where my research is. It's really to develop computational frameworks for getting at these programs of life, making use of all these huge data sets that are becoming available in the biomedical sciences. And so maybe just to get to one question is like, well, we all know like machine learning has been everywhere. So why do we even need new computational frameworks for biomedical problems? And so I think, unlike, and this is like kind of important, unlike drivers of research in machine learning and artificial intelligence, such as, say recommender systems like Amazon or online advertising, biomedical sciences are really different. I think here it's like really important to discover natural laws, to really understand the underlying mechanisms, and I'm sure we'll hear about that also in drug discovery. And here just, your standard predictive accuracy is just not sufficient. And, in some sense, just to give an example, if you're thinking of say, a recommender system like in Amazon, if you know that someone is interested in buying sunscreen, then this person might also be interested in ice cream. And that's just sufficient to understand that, right? You don't need to understand the reasons like, oh, yes, maybe the weather is good and that's why you want to have both of it. But in the biomedical sciences, we really need to understand the underlying mechanisms. You cannot just go by associations, which is, what neural networks, for example, are really good at picking up. So if we're thinking of diagnostics, right, there, for example, if you have like data sets that are very biased, and there is in fact a very nice example of this melanoma, very, very classical example of a melanoma classification challenge where you want to distinguish between benign and malignant skin lesions. And there, in fact, in this particular data set, if you just train a neural network, your standard, top performing classification methods, they will actually learn to identify bandages in the picture just because the malignant data set is overrepresented for these. So obviously, this is not what you want to be using in a hospital setting. You really need to get at the causal features for diagnostics, for drug discovery. And so one of our main questions in our group is really, how do you go from these large data sets to really getting at the underlying mechanisms? And so there are a lot of foundational questions on the computational side that need to be answered in order to get to have an impact on the biomedical sciences. And just to end like this thought, I think, pushing this field forward really requires computer scientists and biologists in academia to come together with pharma and tech industry. And tech industry, because some of the best work today in machine learning is, not only done in academia, but in fact, in the tech industry. And then, of course, pharma industry and health industry more generally, to really be able to identify what are the most important and most relevant problems, and then be able to, the work that we're doing also in academia, to be able to then work on these important problems and then also directly be able to translate them and actually have an impact on human life. And so with this, I'll turn it back over, and I'm sure the others will say much more about this interaction and how this could be fruitful.
I'm sure they will as well. Caroline, thank you very much. Inspirational stuff. Remember, if you're watching this and you have a question or an observation that you want to make yourself, feel free to use the chat function on the platform to ask your question or to share your particular point of view. Use the chat function on the platform. So Caroline, thank you very much. Next we hear from Dr. Lindsay Edwards, who's Vice President and Head of AI, Respiratory and Immunology at AstraZeneca in the United Kingdom. He's going to explain how some of the research, as illustrated so brilliantly by Caroline, translates into applications.
Thanks, Declan, and thank you, Caroline. That was a brilliant intro. I'd actually like to come to this from a slightly different angle too, which is I really like to make this distinction between machine learning methods used to analyze data and glean insights versus engineered systems, because that's the kind of central theme of the summit. And the reason I think that's important is because, firstly, a lot of the impact of machine learning systems recently has been around deployed systems that act as agents. I think if you pull somebody from the street and talk to them about AI, that's broadly what they think of. So a system that drives a car, or a system that supports diagnosis, a system that plays a game. But I don't think we've really seen the impact of that yet in pharma, and it's something that my team is really working on. The reason that's important is because to build these deployed systems and to use some of these methods that Caroline was talking about, you very quickly get to systems of high complexity. And the sort of traditional Jupyter Notebook, one person writing code thing starts to break quite quickly. And you get into this realm of machine learning engineering as a software engineering discipline, because you need multiple people working on a single system, including data engineers and machine learning engineers. So they need to be able to collaborate effectively over a single code repository, which means that you need to write good quality code, which is modular and human readable, and needs to have tests and documentation and all those kinds of things. And also there's a sort of move recently towards composable ML, so use of existing systems to sort of combine them into something larger and more complex. Again, that just sort of adds to the complexity of these systems. And I think it's something that maybe is increasingly recognized in certain areas. So the tech sector, like Caroline was discussing, but maybe not in other industries. And it's certainly something that presents, I think, a unique set of challenges, both in terms of the infrastructure that we build on, and the sort of field of ML ops, ML operations is definitely something that's very lively at the moment. Finding people who have that hybrid skill set, so they have a deep technical understanding of machine learning, but they also know how to build things that don't break. And then, just running teams like that efficiently within organizations that maybe aren't engineering organizations. So Pharma is a good example where it's mostly scientists. It is a sort of challenge in its own right. And then there are kind of architectural considerations. I was listening to a speaker earlier on talking about kind of multiple data sources and using things like meshes to be able to access data in real time. Oh, that's the other thing as well. If you're running a live agent, then you need to have, streaming data. You can't, for example, manually curate a single data set. Everything has to be pipelined and joined up efficiently. And so this is a significant engineering challenge, and it reaches far deeper into traditional software engineering, but also areas that are still kind of actively being researched. So I think that's one area that's very live and present for me at the moment. One thing that Caroline mentioned that I think is really interesting too is on this interface between the kind of machine learning and biology communities. Is machine learning is sort of canonically built around these benchmark data sets and this effort to drive down losses on a particular task, which has been very successful in machine learning. One of the interesting things in biology is when you start to encounter these biases, for example, I'm trying to think of another example, but the biological and pharmaceutical literature is just full of human biases. The most obvious one is that there's very few true negatives in the biological literature. There's very few true negatives in, for example, some of the clinical data that's out there. So kind of being able to train machine learning models that are aware of those things and still function correctly. The reason I raise that is because often you'll find that a good model has poorer performance measurements than a poor model, which is counterintuitive because you're working to remove, like the model that predicted based on bandages might look really good, but it's no use to anybody. And when you then train a model that is able to kind of take into account the causal relationship between the features and the output, it might initially look worse to a machine learning person who's not encountered these before, but is actually far more useful. And that's something that we come across all the time, that the problem actually gets worse before it gets better because you spend a lot of time iterating backwards and forwards with experts, getting them to kind of give you feedback on the model that you're building and what it's actually doing, and then going back, redesigning the architecture, going out again, showing them something, coming back again. So that interface as well is, I think, a really fascinating challenge. And then ultimately wrapping all of that into a system that generalizes and performs well when the user finally needs to use it for something. And again, we function in a regulated environment where it's still a sort of involving conversation between the AI, biomedical communities and regulators, exactly how we properly regulate these systems to make sure that they deliver the value that we all want them to for patients. So I'm going to leave it there and bounce back to Declan.
Lindsay, thank you. Dr. Lindsay Edwards there. Remember, the chat function is there for you to ask your questions, to ask for further erudition or explanation of the points that our contributors are making, or even to add your own perspective as well. Use the chat function on the platform. Now for Dr. Marcela Vizcaychipi, who's a consultant in anaesthesia and intensive care medicine at Chelsea and Westminster NHS Foundation Trust, one of the big hospitals in the centre of London here in the United Kingdom. She's going to contribute her perspective as a medical practitioner.
Okay, thank you, Declan. Thanks, Caroline and Lindsay, for such a fantastic introduction to a big issue in medicine. So until recently, cellular or biology was running parallel to what was clinical or bioengineering and what clinicians like me actually practice. With advance of technology and advance of data, what we have seen is that we are able to see patient's body as a data point. So today, the way that we practice medicine, that is basically we use electronic medical records. We are able to understand the anatomy inside out of our patients. That allow us to actually use the data of our own patients to predict and to identify the risk. So we bring to the day-to-day medicine information from basic sciences. we use information from cohort of patients to model what is going on with our current group of patients. And not only that, I think that what is important is that machine learning, artificial intelligence, and as you said, there are multiple people from multiple disciplines working together, trying to find an answer to a problem. With the pandemic, we have seen an explosion of this. We see a proliferation of group of people working together in order to find a solution. And that's what we have done in my trust, for instance, that is leading in technology and innovation. And we work in a multidisciplinary team. One of the things that we have done is straight away say, we got a problem here and of a disease that we don't know. Let's go and look at the data. So we were in contact with the clinical informatics team, and we have been collaborating with the industry because we work in partnership with Ensign Health, for instance. So we said we need to start looking at the data from the clinical point of view. Is there a signal so we can identify at very early stage things that we can manage at the front end while the scientists were working on trying to identify the behavior of the virus, for instance, or trying to create a vaccine. We are talking in March 2020, we were already looking into our patients' data to see how we can predict the patient risk. And that was the question that I posed to the team. He said, there's any way that I can use my patients' own data to identify their risk of needed mechanical ventilation, their risk of needed admission to the intensive care unit, or what the mortality was at the point of entry to hospital. We got that data in the system. We started sharing that data across organizations. So we could model all the physiological data of our patients, the medical condition of our patients, the demographic. And with that, we can actually start predicting at the point of entry to hospital what was needed for them. So we could deliver better care and support those individuals when they came to hospitals. And so we learned a lot over the last 2-3 years with the pandemic. But now we are moving forward. If we could do that, as a group of individuals, now we found that using the informaticians, a part of the clinical team, and help us to visualize our patients, see our patients from a different angle, will help us to prevent progression of disease. Because it's not about treating. I am an intensivist. So as intensivists, we are very good at supporting organs and understand the physiology and the cellular response to drug A or to drug B. But that's not good enough. What we want is identify the problem at much earlier stage so we can prevent progression. And that will come technology. That's when we start using the data. It's very important that we share the data so we can improve our model and our analytics. And I think that this door just opened. And from now on, I think that the way that we treat our patients will be completely different as it was 10 years, 20 years ago. And we will not see many patients very, very unwell. What we will see is diseases at much earlier stage that will introduce new challenges to medicine. And that's when we need to be kind of eye-opened. We need to have our eyes opened and see how we can manage these new conditions, because it will be new to us. For instance, we know very well how to manage diabetes at the end stage when the disease is fully established. But in years to come, we will identify a potential patient, the potential diabetic patient. So what do we need to do at that time to prevent the development of the disease. So I think that perhaps with this, I summarize how I see medicine, where we are and where we are heading, and how we as a multidisciplinary team can make it better for the next generation. So I'm back to Declan.
Marcela, thank you very much. And whilst we have a global audience watching this session today, I know that our audience here in the United Kingdom will join me in saying thank you to you and your colleagues at Chelsea and Westminster and across the National Health Service for all that you've done for us over the last year, 18 months during the pandemic. Thank you all very much. Our final contribution from Alan Payne, who's the Chief Information Product Officer at Sensign Health, also based here in the United Kingdom. And Alan is going to share his insight into the development of applications used at Chelsea and Westminster Hospital. Alan, over to you.
That's great. Thank you very much. And an absolute pleasure to be here. Following Caroline, Lindsay and Marcela is no easy task. So thank you for your great insights. So at Sensign Health, we sit at an intersection between machine learning, pharmaceutical industry, healthcare, software engineering and regulation. In fact, we only develop regulated products. And that's led us to some interesting insights. The first of which is that you can't achieve practical outcomes in these fields without having a passionate and curious set of clinicians and questions and problems that need to be answered. And as we've evolved our thinking around this, it's clear that without the lowering of traditional barriers of data sharing and of opinion, we're not going to achieve what is truly an opportunity to create far better crystal ball gazing, so to speak. By which I mean, there's an opportunity to take vast quantities of data that we've never seen before, digital biomarkers, digital exhaust, if you will, from other ends of the spectrum, things that Caroline mentioned in terms of the recommender platforms, and actually apply that at scale to a level of personalization or hyper-personalization that's not been seen before. And we can only do these with techniques that cross all of these different boundaries. The regulation, particularly, is it safe? Is it meeting fit for purpose? Does it meet a market need? And can you surveil it after it's actually in production? And for us, that was critical, as I'll explain in a second. Lindsay also mentioned some great points about the extension of what's classic DevOps now into ML ops. And we've had to redesign a lot of our processes specifically to support Marcela and her team of ICU consultants at Chelsea and Westminster. So the crystal ball gazing for us was around how do we make intuition and the fantastic knowledge that these doctors have at the front end, at the coalface, and also during a particularly difficult time. How do we make that understandable? How do we give it to them in real time so that they can actually use that data in a real format, a real situation? As an academic exercise, as a research, you could work on retrospective data. What we have here is the need to deliver something that is in a time frame that is meaningful to the clinician and absolutely meaningful for the patient in terms of clinical safety. If we can help with these decision-making capabilities, where you make a difference, you can diagnose earlier, you can prevent the need for mechanical ventilation, etc. It doesn't just have a huge impact on clinical safety; it has a huge impact on the cost benefit of an economic operation of the hospital. So the problem statement that our fantastic partner Marcela and her team at Chow West gave us was, how do you crunch this amount of data, support a clinical outcome that Marcela's already mentioned surrounding move into ICU, mechanical ventilation, mortality, and how do you apply that in an ethical format that would meet a regulated measurement? So no easy task, and we went through a lot of iterations and Marcela a lot of late nights. But what we ended up doing is redesigning a lot of the processes and throwing away some of the historical thinking that you would have in this space even around DevOps, and re-architecting to fit that within a machine learning environment where we were crunching in the region of 49, 50 plus dimensions of data and delivering that back within 15 to 20 seconds. at a patient level, which is meaningful then for the clinician to make a decision. So for us, this was an eye-opener, certainly for me. Definitely one of the most fascinating projects. It's been my luxury to work on, quite frankly. But it's this intersection of all these different capabilities, the reduction in the barriers to entry, the barriers to being open about what you're needing to achieve. And I think only during a pandemic, it can really show you what can be done, by opening those barriers that have historically been a little more siloed. And then the ability to deliver something that is meaningful. And I think that's what really drove all of us throughout this project, was just the pure passion and energy to solve a really difficult problem at scale. And out of it, we've created a repeatable engine. So what research has led to at one end of the spectrum is now an engine that can be used across multiple conditions, multiple disease states. So for us, it's been a very powerful lesson. And again, it's this intersection and this improvement to create, quite frankly, better crystal ball gazing. Thank you. Back you over to you, Declan.
Alan, thank you very much. I'm interested that both you and Marcela have sort of echoed on a similar point, that the use of data in medicine, in hospitals, in healthcare has changed under coronavirus. And that echoes a point that Professor Dame Wendy Hall made in our earlier discussion about the quality and integrity of data. Alan, just say a little more about that point you made, that it removed barriers.
So the movement of data has information governance implications. For example, we did not want to know who the patient was as we were running the in terms of being able to identify them. So we had to construct a mechanism by which the Chelsea Westminster could anonymise the data to a sufficient level, in fact, fully de-identified and anonymised. We would then receive that data in that fashion, be able to create the algorithms, working closely with Marcela and her team, to a very, very high level of accuracy, and then pass that back where it's decrypted on the trust side. So we had to create that whole information governance component so that we only worked with fully anonymized data on our side, but Marcela and her team could see the outcomes at a patient level and be able to identify who that record was for. So you can imagine the safety implications for that if you get those wrong. And as a result, we built the whole solution as a regulated CE marked algorithm, a software product, and we actually have to do post-market surveillance to ensure that it remains its accuracy. So it's the information governance process that was the key there, Declan.
Caroline, I wonder, could we get your perspective from the United States on this, on whether coronavirus and the response of the worldwide medical community to the pandemic has accelerated some important changes in the use of data in your field? What do you think?
Yeah, I think this is a really great question, and actually something that will relate to what Alan has just talked about is like the data is actually being, shipped over, right? And then there is a lot of questions of like, well, should these algorithms actually directly be run in the hospitals themselves, and the data actually remain there? And in the US, of course, there is now a lot of emphasis on actually putting also the data, for example, maybe in a cloud, and then having the algorithms run in the cloud, so the people who develop the algorithms will never be working directly with the data sets themselves, so that you can kind of mitigate some of these risks. And particular because these people like me, right, on the machine learning side, you need to go, and it is right, you should be going through a whole lot of training, etc., in order to be able to actually work with these kinds of data sets. And so that's a big hurdle, in fact, for students, for example, even in my group, right? So I think there is I think there should be a lot of research in terms of like, how can we actually get these models maybe either directly employed in hospital settings, or have it more be run on the cloud, where we'll never be really directly touching data from patients. And so there has been a lot of effort in this, and I'm part of the Broad Institute, where we're building a new center, this Eric and Wendy Schmidt Center, where this is a big emphasis of actually let us just do that directly in the cloud and build actually the infrastructure in the cloud that is secure. That's the main property there, so that we can then run everything there.
We've been asking our global audience to participate in this discussion using the chat function on the platform, and they've been asking their questions and sharing their perspectives as well. Let me pick up a couple of the questions that we've had around that balance that is struck between more personalised healthcare and compliance and privacy. Dr. Lindsay Edwards from AstraZeneca, perhaps I could get your thoughts on this as someone who has great experience in dealing in a regulated environment. How is that balance to be struck between personalization and privacy?
I think it's an ongoing dialogue with patients as well, because it's a fine balance to be struck between I think time and again when patients are asked, they want their data to be used, but obviously it's what it's used for and under what conditions it's used. I think we also have some fantastic sort of technological developments in the last, I guess, 5 years around things like differential privacy, which kind of bring a slightly more mathematically rigorous approach to privacy than some kind of traditional ideas like anonymization. I think those things are very powerful. There's an awful lot to this, though, and there's another aspect of the kind of regulated sort of regulatory field. Funnily enough, we had an EMA meeting recently that I was involved in to sort of discuss some of these issues, and it would be a question that would be interesting to hear Alan and Marcela's thoughts on, which is around this distinction between the sort of the assessment of the model from a machine learning perspective, so accuracy, for example, some traditional metric, and what's sometimes called the second order effects. So which for me would mean patient outcomes. And I think that's something that still needs to be explored, because ultimately what's really important is that the patient outcomes are better as a result of what we do. And that's not necessarily a direct corollary of a high performing model. Actually, at ICML last year, there was a session where this was raised, and it comes up in lots of different sort of areas where models are deployed. But I think it's particularly important for us. So that would be something that I'd be interested to hear the other panelists talk about, which is, this difference between traditional measures of model performance and the most important thing of all, which is, are our patients better off as a result of this system?
Well, let's put that question to Marcela. Lindsay, if you can just put it as a question once again so Marcela gets it.
So Marcela, how are you thinking about the difference between model performance, which is a nice simple number, and the actual outcomes for your patients? Are you able to monitor how the patients are doing as a result of having the system deployed?
Yes, I think that one of the things in medicine that we always have are static predictive modeling. We got scoring systems that we normally run when patients come into hospitals, and that predict the mortality risk, for instance. And that is a static number based on historical numbers or data that was published in the past. And with machine learning, with this system, what we introduce the real-time analytics, that we use the patient's own data, and whatever value it comes belongs to that individual. So, and then we look at the mortality, because we got two types of outcomes in hospitals. We got the hard outcome, that is mortality. And then we got soft outcomes, that is length of stay, a reduction of complications, and reduction of infection, so on and so forth, better sleep. So when we talk about hard outcomes, it's very difficult to say 1 + 1 is equal to. Okay? In medicine, sometimes we think that because we introduce treatment A, patients do better if we introduce treatment B. And strictly speaking, in medicine, it's very difficult to say that treatment A was better than B. I know clinical studies show that A was better than B because we use cohort of patients to compare A and B. But in real life, patients are unique. Each individual is unique. The physiological response to an stress or to a disease is unique. And that's the thing that we never ever were able to do and look at in the past. Because you can have individuals the same age, the same gender, the same ethnicity, the same medical conditions, and the same infection. And one individual survived and the other died. And the two individuals received exactly the same treatment. And why is that? Because there is an individual response. And that's what machine learning, and artificial intelligence will allow us. We try to put all the variables of each individual together to predict their outcomes. And currently, what we have seen, for instance, from the COVID point of view, what we were able to identify was patients at much earlier stage. And I'm proud to say, could be better, but our mortality in our organization, or the organization where I work, was lower than the average. And that was before we introduced all the treatment targeting the virus, before we introduced the treatment that was related vaccination or the treatment that were identified in clinical trials. And that not because we are better than the rest of the clinicians, it's because we could pick up people at much earlier stage, so we could hold on that. So I think that this is the beginning, as I said before. I think that in years to come, we will start with machine learning, identify patients or diseases that we need to approach from a different angle. And that way comes the research component that will allow us to target that. But for the time being, and that is from my point of view, what we can do is identify problems at much earlier stage. And then, of course, we will need to look at the impact of that type of approach to care. And that's what we started doing at Chelsea, for instance, my hospital, with this sign code that was particular thing. We started looking into actually how the system performs and look at different variables to see if this is having an impact on our patients. At this stage, it's very difficult to say. I think in years to come, it will. At this stage, what helps is the organization to allocate resources and identify where patients need to be moved into in order for us to provide the best care to them. I think that is what we can do and we can say, being frankly honest. I think that we are not in a position yet, and I don't think that people are in a position yet to say that because we deploy real-time analytics, we change patients' outcome. We do better, but I don't think that we can say that we change outcome. I think we need to start developing and working together with the scientists, engineers, and patients as well, because we need to redefine outcomes so we can measure them.
Thank you very much. And I want to thank all of our panelists for their contributions and for sharing their insight with us today. You'll join me in thanking Caroline, Lindsay, Marcela, and Alan. Thank you all very much.